faculty and delegates to join today's session. So it's a great pleasure to welcome you all Onco Update 2024 NGI and Hepatobiliary Cancer. And I would like to invite Dr. Ankit Batrasa. He's a associate professor medical oncology, CRIHIMS Dehradun, to give us an opening remarks and proceed the coordinate the session. So it's over to you, sir.
Thank you, Gitika. So we'll be beginning with the day two of our Onco Update 2024 with a focus on gastrointestinal and hepatobiliary cancers. We had a wonderful discussion about the colorectal cancers yesterday, and today we'll be discussing about BTCs and hepatocellular cancers. So I welcome everyone to be a part of this event and share knowledge so that we can become more wiser and uh, give the benefit to our patients. So, without wasting much time, we'll begin with our first scientific talk. And our first talk is sponsored by AstraZeneca. And we'll be discussing about the new standard of care in the management of first line BTCs, that is durvalumab, along with the standard chemotherapy backbone, that is gemcitabine and cisplatin. To deliver this talk, we have with us Dr. Ramesh Sharawat sir. He is an associate professor in Department of Medical Oncology and Hematology at AIMS Rishikesh. So, welcome you, sir, and over to you for your talk.
Thank you, Dr. Ankit. So I will start my screen.
Sir, is it possible? Can you please open your camera?
No, it's not possible right now.
Okay.
Are you able to see my screen?
Yes, make it full screen.
Yeah.
Yes, it's
Am I audible clearly?
yes, sir.
Okay, thank you for confirmation. Thank you, Dr. Ankit, for inviting me to be part of this academic event. So today we are going to have a quick overview of durvalumab plus Gemcis as one of the standard of care option in management of first-line biliary tract cancers. So these are my disclosures. I have edited some section of AstraZeneca provided PPT, and there are no financial disclosures attached with my presentation. So as we know, gallbladder cancer incidence is one of the highest in India, especially in the northern part along the Ganges belt. After the South America, India is having one of the highest incidence of gallbladder cancer. Not just like that, most of the patients in practically are about 90% of our patients are just palliative patients. They present with the heavy disease burden, obstructive jaundice, practically not fit for just limited few options, whatever we are having to offer them. And that makes it one of the worst possible oncological diagnosis in Indian context. So what is current standard of care management of biliary tract cancer? So before that, I would like to share this slide. This is less than 2 years old slide. And the only preferred category 1 treatment option was just gemcitabine and cisplatin and nothing else. Rest everything was just other recommended options or palliative and limited efficacy. So that was just 2 years back. And that evidence of category 1 that came 14 years back in 2010 trial of gemcitabine plus cisplatin, that is ABC02 landmark study, offering 11.7 month of median overall survival with gemcitabine plus cisplatin versus gemcitabine alone. So that remains standard of care for 12 years or so. So for a decade or so, there was no treatment option which was improving overall survival in this deadly disease. And there has been very permutation combination that has been tried, real world evidence, especially from our North India, TMH, Delhi AIMS. Various permutation combination of gemcitabine and platinum was tried, but end result was that there is nothing more efficacious, or at the max it can be similar, can have similar efficacy as compared to gemcitabine plus cisplatin. And one such option which seems very promising was gem plus oxaliplatin. This TMH review was also suggesting that only that median OS was around 8 months, irrespective whether we are offering Gemcis or Gemox, the toxicity profile was different. Our own experience, we did this as a part of DM oncology thesis project. We compared gemcitabine plus cisplatin versus gem plus oxaliplatin. This paper was presented at ESMO GI conference in Germany this year. And our experience was almost same. So we are having around 7 to 8 months of OS with differential toxicity profile. Other permutation combination of like continuing gemcitabine after a certain set of oxaliplatin cycle That was also in conclusion, there was no survival benefit with this approach also. So we were having very limited therapeutic options in terms of cytotoxic chemotherapy, and that has been tried for more than a decade with various permutation and combination. So then this hypothesis of integrating immunotherapy into the chemotherapy came. We were having successful experiences in our lung cancer thoracic oncology group. So the integration of immunotherapy in biliary tract cancer was a promising hypothesis. So this was tried in this first of its kind landmark uh, trial, that is Topaz 1. It's a phase 3 international randomized double-blinded trial which compared gemcitabine plus cisplatin uh, with addition of durvalumab versus placebo. So this was the trial design. Study eligibility criteria was locally advanced or metastatic biliary tract cancer. Both cholangiocarcinoma as well as gallbladder cancer were included. Two main category was included. One was previously untreated, unresectable metastatic, or second category was recurrent with more than 6 months of curative, more than 6 months of adjuvant therapy completion. So these groups were randomized into 1:1 ratio. Total number of patients were 685. Intervention arm received durvalumab 1500 milligram every 3 weekly up to 8 cycles in combination of gem plus cis. And after 8 cycles, chemotherapy part was stopped and durvalumab was continued every 4 weekly till disease progression. In the comparative arm, we had gem plus cis with placebo for 8 cycles, and after 8 cycles, chemotherapy was stopped. This is one of the criticism with the trial also, that if patient is responding, why you are stopping with gem plus cis. But actually, this was the trial design, and rest of the things we are going to discuss later on. In terms of patient demography and baseline characteristics, everything was comparable. There was nothing much to discuss. Patient, when the study was reported first time in 2021, at the time of reporting this initial data, 18.6% of the patient were having ongoing therapy in such a deadly condition after, say, around 2-3 years of recruitment process. Still, around 20% of the patient were still on intervention arm, as compared to but just about 6% of the patient in placebo arm. So that was the difference. Otherwise, most of the baseline characteristics were similar. Now coming to the endpoints, most important endpoint, the primary endpoint, that is overall survival, Druva plus Gem plus Cis, that was 12.9 month, as compared to the standard of care that was 11.3 month. So there was about month and a half more overall survival with the hazard ratio 0.76. So this was first of its kind, first time in more than a decade that there was one intervention which was offering survival benefit, and that too more than 1.5 month uh, in this group of the patients. In terms of subgroup analysis, most of the subgroup were faring well. There was not much of a difference. All the patients with all permutation combination subgroup, they were having similar kind of outcome with the intervention. In terms of PFS, the median PFS in the intervention arm was 7.2 months as compared to 5.7 months in the control arm. And the similar story was with the subgroup analysis. Now coming to the overall response rates, about 25% of the patient were having objective response rate with the durvalumab plus gem plus cis combination, as compared to 18% in the so-called standard of care gem plus cis for 8 cycle. And about 26% of the patient, they had disease control beyond 12 months, that is beyond 1 year. So the duration of response was 26% at 12 months as compared to 15% in the gem plus cis arm. So there was significant improvement in PFS, there was significant improvement in overall survival. And as we see with any other immunotherapy trial, those patients who are having response with immunotherapy, they continue to have durable responses. So the story was continued here also. Those patients who are having responses, they continue to have, but they tend to have longer disease control as compared to those patients who are not having responses. In terms of toxicity, practically both the groups were having exactly same kind of toxicity. That means vast majority of the toxicity adverse event were because of chemotherapy alone. So the addition of durvalumab immunotherapy part was not changing much. So most of the toxicity are common that we see with gem plus cis in our day-to-day practice. So similar kind of a picture was there in this study also. There was not a significant impact of durvalumab toxicity. The toxicity of concern with the immunotherapeutic agents, that is adverse event associated with immunotherapy agents, that was just about 2.4% in terms of more than grade 3 toxicity. So it was a manageable toxicity. There was no new red flag. Whatever toxicity we are expecting with the chemotherapy, similar kind of profile our patients were having in this study group. The latest evidence from this trial, this was presented this year only in Italy as a part of Cholangiocarcinoma Foundation annual conference in 2024. At 3-year median overall survival in our intervention arm, that is in durvalumab arm, was about 15% as compared to about 7% in the control arm. So the 3-year overall survival was doubled by the addition of durvalumab into GEM plus CIS. So this is all the conclusion was presented in this latest evidence from the Topaz 1 study. So there was one part of the study to see the various permutation combination of mutations and how that is impacting the outcomes in this study. And this is the pattern of Topaz patients who were subjected to molecular profiling, the comprehensive molecular profiling. About 48% patients, they had TP53 mutation. And you can see the green part, the green bars are showing those mutations which are targetable. So only few targetable mutation in gallbladder patients, and that is probably the reason of poor survival. Despite all the advances in molecular biology, we are not able to change much. So similar story was also there in Topaz 1 also. Only KRAS, which is having just recently, we had some targeted therapy. Other than that, there was nothing much to offer in terms of targeted therapy. However, the response rate of durvalumab was similar across most of the subgroup. There are certain exceptions, like if there is a HER2 amplification, that subgroup was not having that much of response. But rest, other than that, most of the mutation, they were having responses with durvalumab. Similar kind of responses with the durvalumab. So as we can argue that the standard of care just offered 8 cycles of GEMSIS, then observation was offered, only fit very good performance score, 0 to 2%, 0 or 1 good performance score patients were included. Then only minority of the patient, gallbladder patient, were included. So all these kind of issues we can raise against TOP as one result and intervention. To counter that, what we have right now, we are having at least two major real world evidences. So one such evidence was from Italy, that was on about 145 patients with all permutation combination of biliary tract patients with poor performance score, transaminitis, drain site, that means biliary diversion intervention was also done. Majority of the patient performance score was also relatively poor, but still, after all these real world issues, median OS was still 12.9 months as compared, and PFS was about 8.9 months. That means as compared to the Topaz 1 trial, similar kind of outcomes were seen in real world scenario, at least in Western population. So next, we can always contest that this is all Western data. What about India? So there has been some Indian evidences also. One such important landmark study, that's one of its kind publication, was there from India. This published just on 5th of December this year. So this is multi-centric collaboration data of about 148 patients of Indian patients, and most common subtype was gallbladder only. So all our concerns are addressed. Relatively poor performance score, gallbladder patients of Indian subcontinent, they were also having similar kind of outcome. The median overall survival in our group of the patient was also 12 months, and median PFS was also 8.2 months. So everything aligned with the landmark reference study of Topaz 1. So these were the group of the hospitals which participated in this collaboration. And we can see that about 2% patients were having complete responses. Partial response was seen in about 28% of the patient. Stable disease was seen in about 24% of the patient. And clinical benefit rate was seen in about 54% of the patient, with objective response rate of about 30%. So having said that, it suggests that there is no doubt whatever permutation combination of biliary tract patients we are treating in our day-to-day practice, if patient is most important point, if patient is affording, then this permutation combination of GEM plus CIS plus durvalumab is going to improve survival rates as compared to all other permutation combinations, standard cytotoxic chemotherapy options. As we have seen that that reciprocal that repetition of ABC02, that has never been possible. Most of our Indian studies, they are saying the median overall survival with GEM plus cis is not more than 8 to 9 months, maximum 9 months. Most of the studies are mentioning just about 7 to 8 months of overall survival with GEM plus cis. However, the real world evidence with Durva plus GEM plus cis is first of its kind of study with median overall survival of about 12 months, and that too from a real world study. So the conclusion was that there is significant proportion of the gallbladder malignancy with poor performance score, high disease burden patients were still having significant implications in terms of improvement of overall survival and progression-free survival. And what is the impact of whatever evidence we have discussed as of now? So within 2 years, we can see total change in the NCCN guidelines. Now the preferred treatment option is ICI plus GEM plus cis. There are evidences for pembrolizumab that is also having equal strength of recommendation. So that is one of the preferred recommended treatment option with category 1 recommendation. And our GEM plus cis, the classical recommendation has moved to other treatment option, although it still is category 1. Having said that, I always go through the NCCN evidence block whenever I am having that kind of decision making. So you can see if you see the more the blue color, that means more stronger is the recommendation basis. The evidence is stronger. So there is not much of difference in terms of recommendation strength. The GEM plus cis is also having similar kind of coloring of the square. However, this is offered as one of the preferred treatment options. The reason I have just discussed that our real world evidence is also aligned with the trial evidence. And this is further supported by ESMO guidelines. The ESMO guidelines are practically more important in our decision making, especially in a developing world, because these guidelines are much less influenced by industry or by the insurance companies. So this e-update, which was published just few days back, published e-update says that if patient is having biliary tract malignancy, advanced metastatic disease, then GEM plus cis plus durvalumab is having highest level of evidence, and that is having maximum meaningful survival benefit. That ESMO scale is also highest in terms of improvement overall survival with this group of the patient. So to conclude, Durva plus GEMS plus cis demonstrated statistically significant overall survival. The 3-year data doubled from 7% to about 15% in this group of the patient. And there was no new red flags in terms of safety. All the permutation combination of molecular profile subtype are also having similar kind of improvement in overall survival. And as a result, DGCI approved durvalumab in combination of chemotherapy in first-line biliary tract cancer patients in India. So with that, I am going to stop. Thank you for your kind attention.
Thank you so much, sir, for a wonderful presentation. Just one query, sir. So after seeing this data from the Topaz one, so do you still consider offering durvalumab to the BTC subgroup, or in you would like to divide whether the benefit is more in cholangio and you will stick to that and offer to gallbladder cancers or primary malignancies or not? Like
Yes.
priority between cholangio versus gallbladder.
As I was discussing, so that was one of the concern that was raised in various platforms, that only that cholangiocarcinoma group that was faring well. But if you see the real world evidence from Italy as well as our Indian publication, which was just this month only, so gallbladder patient, they are also having similar kind of improvement in survival. All that if you see the numerical value might not be the same, but there is significant improvement. And as I was discussing, if you go through the real world evidence of GEM+cis or any other permutation combination of chemotherapy, the median OS from Indian subcontinent has always been 7 to 8 months. And here first time we are looking at about a year. So that means there is significant impact across the biliary tract cancer, including gallbladder cancer patient.
So you are convinced that we can offer equally to gallbladder as well.
Theoretically, I am convinced, but practically, obviously, most important are logistic concerns. So practically, only very minority patients they are going to be eligible for this patient unless there is some studies ongoing.
And do you see anything like even maybe hypothesis generating any biomarker or anything which can guide us better in selecting patients for immunotherapy? As of now, the benefit is irrespective of the PDL1 status. But anything we can take from this, or in future we
So
can think about.
they actually did comprehensive molecular profiling, and there was no marker which was faring much better as compared to rest of the markers. So there was not much of a difference in various permutation, combination, or mutation profiling at least. And in terms of classical PDL1 and that MSI, that has also been not been proven to be of any use till date. In future, we can see some evidence in retrospective basis, but currently there is no evidence that is supporting our decision based on some kind of molecular profiling for immunotherapy than against immunotherapy. However, only one thing we can see, those patients who are having HER2 overexpression or a mutation, relatively this group of the patient might not be that appropriate candidate for immunotherapy.
Agreed, sir. So thank you so much, sir. Moving forward, we have a very good panel discussion on the management of advanced biliary tract cancers. And to moderate this panel discussion, we have with us Dr. Isha Jaffa, ma'am. She is assistant professor and HOD Department of Medical Oncology at King George Medical University, Lucknow. I welcome you, ma'am.
Am I audible?
Yes, ma'am, audible now.
I've shared the PDF, actually PPT I was unable to share. So I think it has gone on this number 8076676269. They can share here.
Gitika, can you check that and share that?
Can you just open it? Otherwise, I have it here, but I am unable to share it. So
Tech support, can you please help out?
Yeah, hello.
हाँ
Yes, ma'am.
मैम ना स्क्रीन शेयर नहीं कर पा रहे, प्लीज हेल्प कर दो.
मैम आपको जूम में एक
शेयर करके अच्छा आई विल ट्राई वंस इसमें शेयर में ना
यस मैम, क्लिक ऑन शेयर बटन ना.
वन सेकेंड
Once you try, otherwise I'll run from my side, ma'am.
In the meantime, maybe we can just introduce our panelists as well. We have with us Dr. Kanika Sharma. She is a associate consultant medical oncologist at Max Hospital, Mohali. Dr. Kanika, you are there?
Dr. Kanaka, hello.
Yeah. Hi. Good evening,
Hi.
everyone.
Good evening. Good evening.
Dr. Ankur Punia, he is a consultant medical oncologist at Mahatma Gandhi Medical College and Hospital, Jaipur.
Hello, Dr. Ankur.
Yeah, hi, I'm here.
Good evening.
Dr. Shashank Bansal, consultant medical oncologist at Chandan Group of Hospital, Haldwani.
Good evening, everyone.
Good evening. Good evening.
And Dr. Abhishek Charan is a consultant medical oncologist at SCG Cancer Hospital, Jaipur.
Sir, he is not there right now. He will be joining in 2-3 minutes. We will
Okay.
wait.
Okay. Can we start the discussion?
Yes, ma'am, please go ahead.
Is it
Ma'am,
visible?
make it full screen,
Are the
please.
slides visible?
Ma'am, make it full screen.
One second.
And now Dr. Abhishek Charan sir is joined, sir.
Is it visible now?
Yes, ma'am. Move ahead.
Okay. So, Dr. Amit has already discussed, and so here I want to discuss with the panel a few of the personal beliefs with practice, whatever they feel as far as CAGB is concerned. So everybody in the panel, please respond. What do you think is the number one cause? Why is CAGB is happening so much like an epidemic in northern part of the country? Apart from what is already established, you can add something to the epidemiological knowledge. So this is an open question to all the panelists. What do you think? Why is CAGB happening?
I think, ma'am, gallbladder stone incident. I mean, cholelithiasis is more common in North India as compared to other parts of India. So that
And
may be,
most of the people do not get it operated on time,
do
right?
not.
That
Yes,
is
ma'am. They
one
do.
thing.
They keep. I mean, delaying it. They don't take it seriously. I mean, I've encountered. I mean, at least in North India, we daily, at least in a week, 2 or 3 cases just because of cholelithiasis. 50, 60 year
Cholelithiasis.
old lady. They had history of stone. They avoided it, and later on it turns out to be malignant after point.
And what about the cholangios? What about the other biliary tract cancers? What do you think? Because cholangio also is coming at a fairly good incidence here in KGMU, what I'm seeing. CAGB is number one, no doubt, but then next to it is cholangio. So what do you think can be the reasons here? Because here we don't get these risk factors like opisthoracis, clonorchis. So we don't find all this. We don't even find a lot of obesity and diabetes related with BTCs in this part of the country. Uh,
But it can be due to the heavy metal exposure that is seen in the water
yes,
levels
that
and
is one
everything.
thing. Yes, that is one thing. Heavy metal exposure in the water supply, some chemical effluents from industries in the water supply, that may be one reason. And another, I think, is most of the patients you would have seen, they will give you a history of salmonella typhi, at least for GB. Many times they will say that it all started with typhoid, and then sometimes we even find old reports of salmonella typhi being there with the patient, and then followed by a diagnosis 3 to 4 months later. So that is something I have seen. And patients are coming from very far away places from the northern part of the country, almost everywhere, all the states, UP, Jharkhand, Bihar, Uttarakhand, everywhere. And patients generally come to us with jaundice, and they are almost sick, have not been eating for say 3 to 4 months. This is the usual presentation that I see in most of the BTCs. So, does the panel also think similarly? Is this the presentation that you also encounter?
Yes, ma'am. Yes, ma'am. I
Yes,
agree.
ma'am. Absolutely, ma'am.
Okay. So let us go further. So, what do you think is the survival in your clinical practice of somebody coming to you with a say localized CAGB, and somebody who comes with a metastatic CAGB? What do you think is the uh, median overall survival in your clinical practice? Anybody and everybody can answer.
Ma'am, in my practice, what I see, if metastatic gallbladder, ma'am, it's hardly 6 to 9 months. And if it is locally, I mean, if patient got operated and if patient was fit enough to get 6 months of adjuvant chemo, whatever chemo, capecitabine or gemcap or whatever, in those cases I have seen they also relapse after a
Okay.
point.
So metastatic setting, that is what I think with cholangios you would be encountering even a lower survival than this.
Yes, ma'am. Yes, ma'am.
है ना?
Intrahepatic and all that, they are worse.
Experience as far as the uh, markers are concerned. For example, what do you think? How long does the HER2 positive CAGB survive? Median survival of a HER2 positive CAGB?
You see, incidence is very less of a HER2 positivity in clinical practice as such. But yeah, after the first line, even HER2 also, the subsequent line, they hardly tolerate actually.
Yes,
Hmm.
they don't tolerate, that is true. And any experience of lepatinib in HER2 positive? CHEB.
No.
Okay.
So, ma'am, Ankit here, ma'am.
Yeah. Yes,
Yeah.
Ankit.
So I have used trastuzumab in one case in third line, and
Combination or separately, one after the other?
combination.
Combination. Okay.
Yeah. So in that case, I think did pretty well, and the progression free is interval was around 6.5 months approximately.
Okay. So, and the total survival of that patient would have been somewhere near 18 months,
Yeah, around, ma'am,
15 to
2
18
years.
months. Yeah.
2 years.
Yes, around 2 years. So I also have similar 2, 3 experiences, but yes, not that much because, as Madam said, we do not encounter HER2 as much. But there's a study from Chandigarh PGI think, where they have also studied HER3 expression in CHGB. They have studied HER2 as well as HER3 expression in CHGB. So, but here, because it's not available, we can't work upon it. So, and what about what is the opinion of the panel, um, as to if you get HER2 2+ in a CAGB? What do you think? Will you do a fish for that? And what do you think are the recommendations on this? And are there any recommendations on this or not?
So, but I feel there is no direct recommendation for gallbladder HER2 testing now because we got some recent data regarding use of trastuzumab, and even HER2 2+ patients have started to show benefit. HER2 3+ definitely, yes, I will like to add a targeted therapy. HER2 2+ is sort of a dicey thing whether we can do a fish, whether fish really makes a difference, we don't know.
Yes. So as of now, we really don't know whether fish would be helpful in this setting or not. But there are some case reports where they have done fish on the samples which were HER2 2+. Okay, so but there's no data which is very convincing. So, and how many patients in your practice present with jaundice? Is it like 70 to 80%, or do you think it is lower, 10 to 20%? What do you think?
It's a one third of the
I'm
patient
sorry.
presents with jaundice.
Mm-hmm. Okay.
Approx 2/3 in my practice,
Ma'am,
ma'am. At
ma'am,
least.
I have seen more than 2/3, ma'am. In
Yeah.
cholangio, almost
I fully
80%.
agree. I fully agree. More than 2/3, even in my practice.
Mm.
Maybe not so much in other areas, but at least in this part of the country, in Lucknow, where we are getting the maximum CAGB. So I think more than 2/3 present with jaundice, and really bad jaundice. Some of the patients come with bilirubins as high as 25, 35, very bad shape. Many of them come in hepatic encephalopathy, and many of them have ascites also. So, and they come on stretcher. There's really nothing that we can do in many of the first timers who are coming to us. What I mean, for the first time, they're coming in really bad shape. So more than 2/3 is what I see here, jaundice. And yes, other symptoms, pain is a important problem. What is the opinion of the panel as far as opioids are concerned in biliary tract cancers? Do you think we should use opioids freely in this set of patients? If yes, why? If no, why?
What I feel is the patients who presents with jaundice, those are likely to have worse side effects with opioids. But as such, patients who present with jaundice don't do well, but whatever kind of therapy we give. Majority of these patients are not candidate even for to give any kind of therapy.
Hmm.
So for those patients, yes, I think we can use opioids because palliation is our main concern rather than giving some kind of therapy.
So I think I'm sure most of you would have felt that some of the patients do not tolerate, some of these patients of biliary tract malignancies do not tolerate opioids that well, and they develop more of
Yes,
side
ma'am.
effects.
Liver metabolism. Yes, ma'am. Hepatic metabolism is
Yes.
in
So because
morphine. We
their
have
FTs
to.
are already deranged, many times
Yeah.
SGOT, SGPT is already deranged. So many times I feel it adds to the constipation, and which they are already suffering from. So I think the symptoms are compounded when we offer them opioids. But absolutely true, we do not have any other better option.
But we don't have any other choice.
Yes,
That's the
true,
problem.
true. We do not have any other better option. Agreed. And what about your experience with patches, fentanyl or buprenorphine in these patients? Are patches doing better, or do you think oral morphine is doing better? What is the experience of panelists?
I think the tablet form is doing much better than the patches. Initially,
Yes.
for the initial control, we can use patch, but eventually they have to be shifted on some morphine tablets or anything, and we can actually modify the dose with it more frequently.
Yes.
I agree,
Agreed.
ma'am. I prefer
Agreed.
step ladder
Yeah,
pattern.
even I agree. Yes,
Mm.
yes. Okay. So, do you recommend doing regularly on IHC, HER2, MSI, and or PDL1 for biliary tract cancers, advanced biliary tract cancers? And is it being done routinely in your hospital?
Yes,
Everybody,
ma'am.
anybody?
Yeah. So in most of the cases, ma'am,
Yes.
I usually recommend them to do HER2 and MSI. Not PDL1, not really, but TMB if possible, and if patient is affordable, then other market like to do. But
Okay.
essentially, I would like I push them to do MSI and IHC at least.
Okay. Okay. So
Okay.
PDL1, as far as the studies are concerned, it's not actually needed in this setting. And MSI and HER2 is something, yes, we would like to do in every case by IHC. And at KGMU here, we are doing both the tests for all BTCs as far as possible. And if we are able to get tissue, okay. So, but comprehensive molecular testing, as advised by the guidelines, the Western guidelines, we are unable to do that. So, is there anybody in the panel who is able to do it for at least half of the patients or at least 1/3 of the patients, comprehensive molecular testing?
Less
Not
than
in the first line, but yeah, in the subsequent setting, if the patient is progressing, then yes, I usually get it done to
So
see if any target is there.
okay. So do you get do you
Mhm.
ask the patient to get a repeat biopsy done, or do you consider the molecular testing on the old sample,
In from the old sample only.
from the old sample only?
Mm.
Okay. So this is an area of research, and I think it is better always, as in the other malignancies, if we, because as the tumor evolves, new mutations come up, and once a tumor spreads to certain areas of metastasis, there also certain genetic mutations are picked up by those clones which have spread. So there can be a difference in the genetic makeup of the metastasis versus the genetic makeup of the primary. And it is, I think, always better. For example, if somebody doesn't have liver metastasis, CAGB doesn't have liver metastasis at presentation, but then eventually after first or second a line of therapy, the patient develops liver metastasis, then um, do you think it will be better to sample from the liver?
So what I feel is if we are thinking of doing a comprehensive, testing, then
So
it's
I
best to
think
do
both
then
should
it's
be
best to
tested,
do
right?
that, so it's best to do upfront and then when the disease progresses, because then we get a better picture of how the disease is progressing, what
Yes,
kind of mutations are happening.
because at least
It gives us
the metastatic area should also be sampled, because then only we can have a comprehensive molecular report for the patient. Okay. So, is everybody following the BILCAP trial as far as resectable disease is concerned? Or is somebody also at some of the centers, are the radiation oncologists offering CTRT in case of close margins or in case of node positive disease at any of the centers? Because it's still not, uh, I mean, sometimes I refer for CTRT in a case of an operated resected CAGB with node positivity, but here nobody is doing. So I just want to know whether it is being done at other centers or not.
Ma'am, what we do in our center is we follow the bill cap as mentioned here. But
Hmm.
in few patients, those who are unresectable but localized, so we
Mhm.
are offering them an option of CTRT. And I think there is a recent paper from PGI Chandigarh also, where
Yes.
it has published in IGRO BP recently, and they have mentioned that the CTRT is beneficial in
Yes, it
such
is
subset of
beneficial.
patients.
Yes.
Yeah. So in such subset of
A
patients,
little
so
personal experience also says that
yeah.
it is beneficial. And
Yes, so
yes,
we are
obviously the
offering them.
PGI experience says the same. Yes.
Yeah, so we are offering them, but it depends again. If patient is having obstructive jaundice, then we first
No,
relieve it.
obviously then it's a contraindication. We can't give,
Yes,
then it's out of question.
yes, yes.
Okay. So in hilar cholangio, there have been selected studies in which they have tried liver transplant. Has anybody tried in any case? Has anybody referred a patient and the patient came back with, say, a 1 or 2 year survival after a liver transplant in a case of a hilar cholangio?
No,
No. Okay. No personal experience also from my
I've,
side.
yes, ma'am. I have not seen.
I have also not seen, but then there is some evidence for that. Okay. So already all this has been discussed in the previous talk as well. So just want to know what is your practice? What is the first line that you are using in a case of, say, borderline resectable, and the surgeon, surgical gastroenterologist, or the surgical oncologist sends to you the patient for neoadjuvant chemotherapy? What do you advise then? And
so
what
if
is
patient
your,
is
yes,
yes,
please.
so if patient is fit, I will advise GEM, cis, and nab-paclitaxel. If we are thinking of going for surgery in a borderline patient, so it has shown to have some higher response rates. So more
Yes.
likely patient can get operated.
Is everybody okay with it?
Ma'am, in such scenarios, I discussed this case in MDTs, and I took the opinion of radiation oncologist also. What is their purview, whether they will be able to complete the radiation in this scenario? In case is the disease is such extensive, they cannot keep it in their portal and expected toxicity is high. Then only
No,
we will consider.
I'm talking of neoadjuvant, neoadjuvant
Ma'am,
setting.
neoadjuvant setting, ma'am, I have treated few patients, but none of them has converted into a resectable.
Okay, okay. So in the second line, what is the chemotherapy that you usually use? Anybody? Dr. Kanika, Dr. Abhishek, Dr. Shashank?
Mostly Folfiri if I have used gemcitabine and cisplatin in the first line.
Okay. And do you think there's a good PFS that you get with it?
For this check, it's
Okay.
usually around 4 to 6 months only.
Mm-hmm.
Yeah.
I prefer, ma'am, Capox, ma'am. And
Okay.
it has shown, I've seen one of my patient is still on fifth cycle.
Okay.
Yeah,
So,
I also prefer Capex.
Okay.
I prefer to give a single agent in the usually second line
Okay.
because it there is an Indian I think Tata study which showed that giving a combination doesn't improve outcomes, just adds toxicity.
Yes, there's a study from Tata saying that, but then we also know that if the PS is good, we have seen that patients go up to even fourth line sometimes. Obviously, if they have not developed jaundice meanwhile, or if they have not worsened. So usually, I use here gemcitabine cisplatin as the first line because durvalumab is not available. Pembrolizumab is sometimes available for some of the patients with a very uh, good CM or PM funding, and otherwise unable to use even Pembro in the first line. So Gemsys and in the first line, that is all I am able to use here. In the second line, I usually use Folfox or Capox, and I keep Folfiri for the third line. That is what is my experience. Any experience with S1 or Tegafur anybody? In any line, in any setting?
So I have not actually used S1 ma'am, but what I have observed, usually my patient when present with you know increased bilirubin, and I usually prefer to go with a biliary drainage procedure followed by a single agent, either gemcitabine or S1. I have read there was some literature that S1 was showing some benefit, but I've not used it. And after all the conclusions also which I have drawn from the studies, this single agent gemcitabine 1000 milligram stat dose does well with these kinds of patients. And once the bilirubin is below the normal limits, we can go switch to Gemcis or whatever we were planning. Not
Yes, in frail patients and with patients who have undergone PTBD or a
Yes.
recent stenting and whose bilirubin is around 2 or 3, and but not more. In that case, I also use single agent gemcitabine, and that does well. And sometimes then patient's GC further improves, and then the PTBD is internalized, and then we are able to use even dual agent Gemsys, or sometimes the PS I've seen has improved, especially in young males. Some of the young males I've seen whose PS really improved over time, and then I was able to use Gemsys and Nab-Paclitaxel. But otherwise, Gemsys is the usual thing that I use, and in elderly I use Gem Carbo. But obviously, with Gem Carbo, I think the PFS is shorter. What do you think? Do you think they're comparable in in biliary tract cancers, Gemsys and Gem Carbo? Or do you think that the PFS is shortened with that?
I
I have
personally
not
feel
used
the
carbon.
responses are low,
Responses are low. Yes,
and
somewhat.
toxicity thrombocytopenia is more with gem carbo.
Cytopenia is more with carbo. Yes, agreed.
And it is pretty tolerable, the Gemsys.
But Gemsys is tolerable, yes.
Mm.
Most of the young patients will tolerate. Up to 65 also patients are able to
Yeah.
tolerate Gemsys, age of 65, yes.
Yes.
Okay, so how many of you are able to use the standard first line Gemsys plus Durva or Pembro in metastatic biliary tract cancers? And what is your experience? Because I am unable to use, because I'm at KGMU, it's a government center, and here we don't have access. Patients are usually very poor. So I'm not able to use frequently Pembro
Very rarely
with
in a
tests.
one or two cases I have given Genesis Duvalimab, and what
Okay.
I felt was my experience though is very limited. There is
Mhm.
not much I mean, I could not see any significant difference. I mean,
Okay.
it progresses after 6 to 8 cycles.
Okay.
Though I've given only two patients so far, so I have very limited
So
experience.
I have used in quite a number of patients, but
Okay.
yes, I also do feel that there is not a very prolonged response, and
Okay.
hardly any 1 to 2 patient is on Durva maintenance right now, and most of them they have progressed.
Yes, that is why, because nobody goes to maintenance. So I really wonder the results of these trials, because because we are seeing in northern part of the country in India, we are seeing, I think, the world's highest CAGB and cholangios, and we are able to get the same results here. So in 2-3 patients in whom I used Pembro, I'm seeing the same thing. I could not, the moment, for example, if one cycle is due to financial reason or some other reason, if they are unable to arrange for one cycle, and if there's a delay, some kind of delay, I think there's a very rapid progression. Initially, they do very well with Gem, Cis, Pembro, but then uh, in two of my patients, there was a very rapid progression when they could not get the fifth cycle on time. So,
My experience is bit of a contrast from whatever been discussed. I've used it
okay.
in only one patient. That is from when I was working in AIIMS Bhopal. So I used it in one patient, and that was a young patient with GB mass and peritoneal deposits, not having
Mhm.
any limits. So I've used durvalumab, and after 3 cycles, there was a complete response. That person completed 6 cycle, and he was on maintenance. uh, After that, I lost the follow-up, but I'm sure that he must be doing well only till now. And he had a CR after 3 cycles of Durva sepsis.
Ma'am, also for Durva, there
Mhm.
differential response between CA gallbladder and the cholangiocarcinomas.
Yes, absolutely. There's a
Couple
lot
of
of difference.
carcinomas, and they are on maintenance. They've completed like 6 maintenance.
Cholangio.
Yes.
Okay. So that is what GB we are getting here more, and cholangios might be doing well. Some of the cholangios might be doing well with immunotherapy. That is uh, the expectation. And because GBs generally don't do well,
Yes, ma'am.
even we sometimes have to discontinue. Even they are sometimes not even able to tolerate single agent gem. Means we start with a good PS, and sometimes it happens that PS worsens over time. So then we have to stop everything. But yes, some of the cholangios do well. Very rightly said, Dr. Sahil. Correct. Okay. So any experience, anybody has read any trial or anything as far as the CAR T cells are concerned, or any cancer vaccines as far as the BTCs are concerned? Anybody? Okay, so moving on to a topic which is not very often discussed, but yes, what is the personal experience of the panelist and of the audience as far as Durva and Pembro, Durva versus Pembro is concerned? Means, what do you think is better tolerated? One, and what do you think patients are doing well on? Is it Durva or is it Pembro? I haven't used Durva much except in one case of small cell lung cancer. So in this set of patients, BTCs, I don't have that much experience of anything other than Gemsys. If I have an experience, I have an experience of Folfox in the second line, then Folfiri in the third line. Only 4 or 5 patients so far could get Pembro plus Gemsys. So what do the panelists think that which is better as far as Indian patients are concerned, cost, side effects, everything is concerned? Durva versus Pembro.
So, what I feel, I've used both the drugs. I
Okay.
personally feel both the drugs are same. Side effect wise, not much of a difference. It's just a personal preference. What do you want to use? We have been using more of pembrolizumab because of broader indications, so slightly more comfortable using that. Otherwise, I don't see a difference between either of the drugs.
Okay. So in the patients, you did not find any difference. So
Mm,
okay.
mm,
In the side effect profile, no,
not much of a difference.
not much of a difference. Okay. Anybody else wants to say something? Dr. Sahil, Dr. Kanika, Dr. Abhishek, Dr. Shashank,
Ideally,
Ankit, Dr. Ankit.
title.
So, ma'am, I prefer durvalumab. I have not used pembrolizumab in BTCs.
Okay.
Although the data, if we compare head to head, is more or less similar. And I totally agree with Dr. Ankur that in other sites we are more comfortable with pembrolizumab. But the practical reason why I'm not using pembrolizumab in BTCs is that PAP is not available for that. So it's become logistically much costlier for the patient.
Okay.
I also prefer, ma'am, Dualumab over Pembro, at least in BTC so far.
Mm-hmm.
I've
Okay.
only used Durva only in BTCs.
Okay.
Pembro.
So, did any of you encounter the autoimmune side effects of Durva or Pembro? And how did you manage and how severe were they?
Not any autoimmune, but yeah, the fatigue was there in
Fatigue is
2 to
there,
3. Yeah,
yes.
fatigue is there, significant, for which I have to stop 1 to 2 cycles in between for
Mm-hmm.
Durva, but not the other pneumonitis or hepatitis.
Okay. Any experience with liposomal irinotecan? I mean, I do
Hmm.
not have access to this liposomal irinotecan, but it is, yes, it is there. And
It is
any
equally
experience?
costly
Yeah,
as compared to immunotherapy, actually.
yeah. So, and any experience of any of the panelists with regorafenib,
No, ma'am. No, ma'am. Not
okay,
in BTC.
with nivolumab?
No.
No. Okay. So, has anybody got this done? FGFR, IDH testing for cholangios and got the mutations present in the NGS study and then used any targeted therapy?
Last week only got a NGS done and have a FGFR2 mutation, and now I don't know what to
Intrahepatic
do.
cholangio?
Yeah,
Okay.
in gallbladder, actually.
Gallbladder. Okay.
Metastatic gallbladder.
Metastatic gallbladder.
Yeah.
Okay.
One
So
BRAF
the
and
yes,
it is on dabrafenib and trametinib. The patient has kind of completed 6 months. So it,
BRAF positive.
yes.
Nice.
So initially, this guy had some temperature rise. So in between, I had to stop the paracetamol-free intervals, the fever-free intervals. I had to see. So, but they were pretty well manageable. Like once or twice, I had reductions of trametinib, basically, not Dabra. So, but it was pretty manageable.
Okay. So anybody getting done uh, MSI by molecular study in BTCs? Like I am able to get only MSI done by IHC. Anybody felt a mismatch between the two things? For example, on IHC, it was coming out to be all the genes intact. I mean, the expression intact. And on the molecular study, uh, it was deficient MMR. Anybody felt like this? And then used Pembro and found some benefit. So I have one such
Hmm.
case in which it came out to be they were by chance having affordability to get a NGS done, and in that it came out to be deficient MMR, and in that one pembrolizumab really worked well, but the patient was having all the uh, proteins expressed. There was no loss of any protein on the IHC. Okay, so these are the genes that they have studied and all the in the three types of BTCs, advanced BTCs. And this is a comparison in which across several trials in which they have uh, seen the ORRs, the PFS with different mutations. So if we see here, the highest survival is with the rarest mutations, and those are NTRK and RET. So, I mean, the highest responses are seen with the rarest mutations. So, but obviously, we don't have access to any of the RET inhibitors or the NTRK inhibitors. So, this has already been discussed by the previous speaker. So, although we discuss the immune related adverse events each time when we give immunotherapy and get scared for the same, I think in biliary tract cancers, whatever little is my experience, and others can share their experience, I don't think we had any significant uh, toxicities with immunotherapy. In GI malignancies, I'm not getting any kind of severe toxicities with immunotherapy. But yes, in lung cancer, we do get sometimes serious toxicities with immunotherapy. What is the opinion of the panel or the audience?
I
I
feel it is. Yes, sir, Ankur
yeah,
sir, first.
go. So I have seen all kind of toxicities with the immunotherapy. It can happen. Anything can happen to any of the patient. So only thing is we have to vigilant about it. That's what best we can do, and you do regular proper monitoring of the patient regarding all the symptoms. Because I've seen all kind of itis from top to bottom. Just we have to be vigilant about it and to catch it early and to properly treat it.
Agreed. So, do you call the patient frequently with the lab tests, as in this slide?
So
Do
I
you
do a bit.
provide do you provide your patients with the booklet?
So I usually tell all the patients who are, I don't have a booklet or any material to give to the patient.
Mm-hmm.
But I explained to the patient that any kind of thing, because the immunotherapy can affect any kind of organ. So any symptom
Absolutely. Hmm.
new symptom you develop, just don't ignore it and report it. Any kind of symptom you
Any
develop
kind of
can be
symptom.
just it can be just basic itching or altered bowel habits. That's the most common thing which we see. So you have to report it. I just explained to the patient, just don't ignore any simple symptom as well.
Mm-hmm.
I
Agreed.
I agree with sir. I have also seen many side effects, and it is less related to the type of cancer. It is individual. I mean, some may develop in RCC, some may develop in lung,
In
and
RCC and in lung, yes, I am seeing toxicities, but yes, in BTCs, but the
disease
reason
are
may
not.
be
But I've recently encountered one lady, 32-year-old cervix, and she had PDL1 CPS5. So I gave
okay.
peclicarbo plus pembro, and she developed, I mean, hepatitis due to pembro. And
Okay.
so 32, I mean, any profile can develop. That's what my personal experience.
Okay. Yes, that is true.
Ma'am, I think RCCs and lungs are receiving more numbers of median number of cycle as compared to BTC. So
Ah,
that might
yes,
be a
that is
reason.
what I was going to say. That is the probable reason for that, because we have definitely used immunotherapy more and for a longer time in these patients. That is the probable reason. Yes.
Ma'am, sorry for interrupt you. Kindly request to you. Please conclude your session.
Yeah. So mostly I have discussed all the points. And is there anything any of the panelists would like to highlight to everybody for everybody's knowledge or anything? There is just one thing that I want to say regarding CAGB. I think there were initially many years back some studies on the use of mustard oil, the use of adulterated mustard oil in development of CAGB. So other factors need to be looked upon, as we discussed in the beginning. Another thing is we should also look upon not only the usage of mustard oil, but the usage of the really bad ones, such as the trans fat, repeatedly heated oils, which are used in samosas and pakodis in market, because people are Most of the people go for it, even in villages. And they are the ones who make the majority of our CHAB patients. And then we should also avoid biscuits and all, because everything contains palm oil oil. So somehow I think palm oil oil is a factor, and it is there in every packed item, even of the good brands. You will find somewhere written palm oil in the contents. So I think that is something that we can educate the public about.
I just want to point out one more thing, ma'am.
Yes.
Uh, as you have talked about samosas, it is not only the oil, but once they take that samosa on a newspaper, and the ink of the newspaper, usually it comes out and along with the skin of the samosa.
Yes.
They are investing
It
it. So
gets
probably
imprinted
that
on the
is
samosa.
yeah, that is also that ink is maybe a one more potential thing.
Maybe, yes. Okay. So thank you. Thanks to all the panelists. Thanks to the organizers. It was a nice discussion. Thank you.
Yeah. Thank you.
Thank you, everyone.
Thank you.
Thank you so much, ma'am, and all the panelists. It was a very insightful discussion. And I think in the era of precision oncology, especially the cholangiocarcinomas are going that way. And it's not very far that we find that cholangiocarcinomas will be treating just like lung and not as a single entity.
Absolutely,
So,
because of the mutations. Yes. Yes.
yeah, so thank you, everyone.
Thank
So,
you.
shifting gears from BTCs, now we'll be discussing about SCCs. So, we have a small talk on SCCs and followed by a panel discussion. So, I request everyone to stay back if they have time. And for next session, which is on SSC, that is the role of tecentric and unresectable and metastatic SCC. We have with us dear friend Dr. Sahil Gupta. He is a consultant medical oncologist at Kailash Cancer Hospital and Research Center, Wagodia, Gujarat. Over to you, Dr. Sahil.
Thanks, Ankit. So, hello everybody. I'll be just sharing my screen. Okay, is it visible?
Yes, sir.
So, I'll be discussing about the treatment paradigms, not only about the role of this atezolizumab, but also other regimens such as durvalumab and tremelimumab, and the local therapies where indicated like TAS, transarterial chemoembolization, radioembolization, then where we can do RFA and liver transplant, the role of upfront downstaging in liver cancers. So liver cancer, it is slowly and steadily coming up. It's the sixth most common cancer and third cause of cancer-related death because of its poor prognosis, the PS of the patient at presentation, and the comorbidities associated with it. It is HCC is extremely heterogeneous. It's a continuous cycle of hepatocyte damage and subsequent regeneration. The causes of continuous cycle of hepatocyte damage have changed over the year in different socioeconomic strata. So here we can see that for HCC in India, we see that initially it was basically due to the hepatitis viruses like Hep B and co-infection with HBV and HCV. And slowly and steadily, we have shifted from the infective disorders to the lifestyle disorders. So this is a major change in the socioeconomic strata-wise distribution of HCC. This we have already discussed. So it's a multidisciplinary approach due to the regeneration capacity of the liver. We have to involve multiple teams, including a transplant surgeon, gastroenterologist, hepatologist, and palliative care and hospice services, medical oncologist, radiation oncologist, intervention radiologist. So, diagnosis of HCC, when we encounter a mass or nodule, if it is less than a millimeter, if it is less than a centimeter, we can keep it under follow-up and repeat ultrasound at 4 months. And if we see that it is changing pattern, then we can go for a CT triple phase imaging, and we can go for a biopsy if indicated. So this is, we can, on multi-phase CT, there are characteristic finding for hepatocellular carcinoma. The LIRAT score is there, in which basically from LIRATS 4 we can say that it is probably hepatocellular carcinoma, and in LIRATS 5 we can see it's definitely hepatocellular carcinoma. So the management of HCC includes the surgical team, the local regional treatment, including ablation and endovascular treatments, the systemic therapy, which initially used to be only TKIs, but now they have been in advancement in the systemic therapy of hepatocellular carcinoma, where we can give doublet immunotherapy, combination immunotherapy, and the atezolizumab, bevacizumab, and SBRT. So this is our previous staging. So when we see the updated BCLC staging, we can see that up to early stage we have the option of transplant. That is when the patient has a single nodule or less than three nodules with less than 3 centimeters size. Also with a good performance status, preserved liver function, and with a normal portal pressure, with a normal bilirubin. So I don't think that we see such patients in our day-to-day clinical practice. I often see advanced stage cancers, and these are just candidates for systemic treatment. For intermediate stage patients, we have the options of transarterial chemoembolization also. And here we see that if the patient present to us in early stage, then we can expect a survival of more than 5 years. For advanced stage, the survival has increased from approximately 12 to 13 months to more than 2 years with the recent advent of combination immunotherapy and the atezolizumab plus bevacizumab regimen. In second line, regorafenib, cabozantinib, ramucirumab, especially if AFP is more than 400, uh, it is very this costly drug. And in third line, cabozantinib. So this is the timeline. We have moved on from sorafenib to regorafenib to lenvatinib. There have been this case studies which have said that for HCV positive tumors, sorafenib may work better. Then the first immunotherapy to be approved was pembrolizumab, and then latest we have atezolizumab and bevacizumab. So coming to the atezolizumab plus bevacizumab in unresectable hepatocellular carcinoma. So most of the patients in our clinical practice, they do not have such profile, the stringent criteria that have been mentioned in atezolizumab plus bevacizumab, uh, the combination. So we rarely have CP, child PUA patients. Most of the patients have hepatitis B, hepatitis C, and people do come us with portal hypertension. So the stringent criteria of atezolizumab plus bevacizumab, we are not able to follow all these stringent guidelines. And there have been data that in patients, there's been study in Tata, they have said that they've showed that in cases where serology, the HBV and HCV positivity is there also this combination therapy does work. So in this, generally, before progressing for this atezolizumab and bevacizumab combination, I generally do get testing done for esophageal varices. I get an endoscopy done, a band ligation if possible, because we don't want the patient to bleed. Otherwise, we'll just lose this line. Here we can see that the overall survival was markedly increased by 6 months as compared to sorafenib. And the we can see for the patient of progression-free survival and the survival without disease progression, the graphs are separating initially and they are maintaining their separation. The hazard ratio, it has a significant p-value, a good hazard ratio of 0.59. Then the quality of life. Personally, I've couple of patients on durvalumab and tremelimumab combination, and as evidently the combination arm of atezolizumab and bevacizumab, or the doublet immunotherapy arm, combination immunotherapy arm, is definitely better than for as compared to sorafenib and this lenvatinib. This is my experience till now. So we do not live in an ideal world. In cases where we do not have the exact population as mentioned in the trial. So across 11 institutions in India, the two cohorts were there in which trial-like setting and non-trial-like settings were introduced, were compared. So the ICIs that were used was the combination of atezobev, nivolumab, and pembrolizumab. So with median follow-up of 13.8 months, we see that the patients who were enrolled according to the stringent trial criteria, they had a significantly improved overall survival as compared to cohort 2, in which the stringent trial criteria was not followed. So this is something I'll be skipping. So in a pooled meta-analysis that had multiple studies, so it was found that irrespective that the patients who met the trial criteria, they did better as compared to the patients who did not met the trial criteria. So coming to the Himalaya trial, including the STRIDE regimen, which had combination of tremelimumab and durvalumab versus durvalumab versus the TKI. So over here we see that the combination of tremelimumab plus durvalumab was better as compared to other arms. The significance being that in cases of atezolizumab plus bevacizumab, patients who have liver cirrhosis, patients who have co-infection, for which we do not have any proper data, whether if cost not being a constraint, can we use this regimen? Because I have just a couple of patients on this, so it's very early for me to state this. So as we see through the three arms as compared with STRIDE regimen, durvalumab and sorafenib, the survival rates and the PFS was statistically significant. And coming to the we have already discussed this regarding the advanced stage. So coming to the liver directed therapies in hepatocellular carcinoma, it can be we can do the chemoembolization, tumor embolization with chemo, radio frequency ablation, transarterial radiotherapy, then embolization with chemicals like ethanol and acetic acid. So the principle of transarterial chemoembolization is that high energy radioembolization is high energy beta radiation triggers the DNA double breaks, resulting in tumor cell shrinkage. So generally for this SIRT is used, in which we are placing some beads around the tumor and we daily contour them, and then focused radiation is given from outside, or this we can do we can just keep these beads near the tumor, so that the beta particles that are emitted from the tumor, they just damage the tissue near around it. The isotopes that are used are yttrium-90, iodine-131, rhenium, and holmium. So the indications are for this are multinodular BCLC B stage, larger than 5 centimeter, or tumor number is more if more than 4. HCC invading branch portal vein after failure of transarterial chemoembolization. DCLD, high lung shunt fraction, and massive infiltrating HCC replacing the whole liver. These are the contraindications. So when there was a trial which compared the efficacy of Yttrium 90 tear in advanced hepatocellular carcinoma. In this we see that as compared to the irrespective of the etiology, the progression-free survival and the survival it is very good. The complications that were there were basically fatigue, abdominal discomfort, fever, bilirubin toxicity, and elevated transaminitis, some amount of myelosuppression, radiation pneumonitis in some cases. So SBRT, it's a highly conformal technique. We do contour the tumor, and we do higher radiation doses in a lesser number of fractions. The importance is that there is a market dose response, that the radiation is limited to this area only, and the dose drop off is very this sudden. But the problem with this is that the beams of the radiation will travel through the liver itself. So the chances of radiation induced liver disease is comparatively higher, especially if we see the patients who are already cirrhotic. So the indication of HCC is that the maximum diameter of should be 5 to 6 centimeter. The locations should be if closer to the liver, so that the normal liver is not involved. Child Pugh score of 8 and below up to 5 lesions, and the platelet count should be more than 50,000. So this is some, I think we'll just skip that. So there is some Indian data also regarding the SBRT. It is basically from Medanta. So the total number of patients that were, and that was a retrospective study, and the patients were classified as they having no portal vein thrombosis versus HCC patients with having the portal vein thrombosis. So they were randomized. So they were randomized to 25 patients were downstage using TARE or TACE or SBRT, and in 21 patients, the patients had portal vein thrombosis either within and this VP1, VP2, and VP3 are the levels depending upon the thrombosis level. So here we can see that the patient who had upfront downstaging, they had better survival, better RFS, better overall survival as compared to the patients who had not undergone downstaging. And this is with regards to the patients who have undergone downstaging and who have not undergone downstaging with respect to the portal vein thrombosis. So here we can see that the patient who do not have portal vein thrombosis and underwent downstaging, they did had a better RFS, DFS, and OS. So to conclude, there has been a paradigm shift from TKIs to immunotherapy to combination immunotherapy with loco-regional therapies like RFA, microwave ablation, transplant. So the management of HCC has to be individualized as per the stage, also as per the patient, and with the advent of local therapies as for downsstaging, I think more and more patients may be amenable to transplant or resection. Clinical decision making with the patient and relatives, including the interventional radiologist, the transplant surgeon, has to be at the core of the treatment. And if we use the therapies, surgical, locoregional ablative, and immunotherapy as systemic therapy, we can afford for a better survival in these subset of patients. Thank you.
Thank you, Dr. Sahil, for touching upon all the modalities used for the treatment of STCs, especially the local therapies. Uh, in the interest of time, we'll move on to our next and the last session, that is the case-based discussion and the optimal management of first-line advanced metastatic STCs. So this will be moderated by Dr. Nagin Sharma, sir. He is a senior medical oncologist and a principal consultant at Max Super Specialty Hospital, Delhi. Welcome you, sir.
Hello, good evening. The most common question which is asked these days is whether my slides are visible and whether my voice is clearly audible.
Sir, slides are visible, but voice is slightly feeble.
Okay. Just one second. Is it better now, sir?
Yes, sir.
Okay. So I will come straight to the presentation, and before starting, I will like to invite my panelist. Right. So my expert panel, Dr. Mohit Saxena. Are you there, sir? From Manipal Hospital, Palam Vihar, Gurgaon.
Yes, sir. I am here.
Hi, good evening. Dr. Vibhor Sharma from Asian Hospital, Faridabad. Are you there, sir?
Yeah, hello.
Hello,
I'm
sir.
there.
Right. Dr. Ishu Gupta from Unique Hospital, New Delhi.
Hi, sir. How are you?
Sir. Hi, sir. And Dr. Javed Mujammil, a very dear friend of mine from Medicare Hospital, Srinagar. Are you there, sir?
Good evening, Dr.
Hi, good
Nagada.
evening, sir. So all the expert panelists are there. So I will come to the presentation then. So as we all know that getting a HCC diagnosis and going through his treatment, it's not only devastating for the patients, it's actually devastating for the entire family. The challenges which this patient faces, they are not only physical, they are emotional, they are psychological, they are spiritual, and above all, they are financial. The first systemic treatment which came into existence for advanced SSC management, where the role of medical oncologists came into play, was not more than 1.5 decades ago. And then when it came out, there was anticipation in medical oncology community that there will be many more trials which are going to outsmart the godfathership of sorafenib in next couple of years, and we'll be having many more drugs. But what we have witnessed in last couple of years after 2007, when the sorafenib trial was published, that there was negative trial after negative trial after negative trial, so much so that advanced SCC used to be called as graveyard of phase 3 studies. Historically, we all know that getting a HCC diagnosis and going through its treatment, it's difficult to treat historically, and majority of patients will succumb to the illness within a year of the diagnosis. The curative treatment, as far as HCC is concerned, we all know that it's either liver transplantation, it's either resection or ablation. There is no fourth way to cure HCC. But on the contrary, majority of patients are getting diagnosed in advanced stages in which the intent of treatment is palliative. We have to keep these patients as good as possible for as long as possible with the limitation of science, and they will succumb to their illness. This is what all of us have witnessed. So today we are going to discuss that what are the changes in last 5 to 7 years which have changed the management of SCC upside down. And if I tell that we are living in a golden era of advanced SCC management, I don't think that's an overstatement. We are having nearly 4 drugs in first line, we are having nearly 6 drugs in second line, and there are many more drugs in pipeline which are going to change the management of SCC, which is good for the patients, and it is very, very tough for the medical oncologists now onwards. When I was a resident in medical oncology in Adyar Cancer Institute, Chennai, my seniors used to scold me. I remember this, that why you are presenting a SCC patient in a multidisciplinary tumor board. And this is not even more than 10 years back, because there were only 2 drugs as far as medical oncology community is concerned. There was sorafenib, and that time lenvatinib came into existence based on Reflect trial, which was a non-inferiority design. So the medical oncologist role ends there if the patient is having advanced SCC. But now we have seen that if we won't present these patients in multidisciplinary tumor board, we are actually decreasing their survival, because there is a VA cohort which is already published, which have shown that if we present the patient in the multidisciplinary tumor board, we are actually prolonging the survival, no matter whatever drug you're using, right? We'll be taking insights from our colleagues and they will tell us that this is the correct way. So it's not the drug which conquers cancer, it's actually the correct sequencing of the treatment modalities, the patient's will to fight against the disease, and the knowledge of the treating doctor, which ultimately conquers cancer. I think everyone will agree to this. So I will come to the presentation. So already my dear friend Sahil have already discussed this, that in India, the liver cancer is the 11th most common cancer type and it's 8th most common cancer which is related to death. And with HCC being the second most common cause of death in men. So Global 2022 data in India, the incidence is 38,000 odd and the death is 36,000 odd patients. That means there's an unmet need that we have to save this patient because it's a lethal cancer historically. Male preponderance with male and female is 4:1. That is just reverse of gallbladder cancers as BTC, in which females it is more common, but in HCC it is males 4:1. Remember that. Median age of presentation ranges from 40 to 70 years and frequency increases with increasing age. The incidence of HCC in cirrhotic in India is 1.6 per year. That means longer the patient lives with cirrhosis, more likely the patient is going to develop HCC over a period of time. So I want to ask my panelist, expert panel, what is their practice? So may I start with Dr. Mohit from Manipal Hospital, Gurgaon. Sir, what is the percentage of distribution of child-big score in your practice? So in advanced SSC, I am very sure that all of us, we are using child-big score. So what is the percentage of child-big A, B, and C in your practice? Dr. Mohit, please.
I would like to say that in my practice, I see less of childhood A, and I think that's the ideal situation that we love to see, but actually we are not seeing that childhood A that common, and many of us are facing childhood C as well. So in my practice, I will see roughly around 30% of patients with the childhood A, and 50 to 60% of childhood B, and almost 20% of childhood C. That's what I usually see. Most of the falls in childhood B.
Fair enough. May I take inputs from Dr. Vibhor, sir? What is your practice, sir? Childhood A, B, and C?
In my practice also, I see almost 20% of A and C and 60% in B.
60% in B, right.
Yeah.
So 20% of A and C and 60% in B. So which drug you are using for childhood B, as far as your management is concerned?
In B7, actually, as per the guidelines, if you see, you can only treat it till B7, right? But if you look at the guidelines, if it is B8, B9 or C, you have to basically only best supportive care is there. But in actual practice, depending on other factors, I have used TKIs also, and I have used A plus B combination also. I have never used durvalumab and tremelimumab so far, or nivolumab, ipilimumab so far in B7. In B8, it's a very gray area, and depending on, it's basically a discussion between the patient and the treating doctor. We have to tell them that the chances of improvement are slim, and the standard practices, best supportive care, we have to counsel them very properly if we want to put them on any systemic therapy. In my personal preference is to go with TKIs because in case of any side effect, you can promptly stop it. And with atezolizumab, bevacizumab, I have seen more of toxicities if they are used in B8 or B9.
Okay. So that's a very pertinent point you raised, Dr. Vibhor. So you're told that for B7, the only data is for sorafenib. You cannot use lenvatinib also for B7, and you cannot use immunotherapy also B7 and beyond, right? So ideally, if we go by guidelines, we cannot use immunotherapy drugs for any of the B or C category of BCLC. So only sorafenib is holding ground in B7. There is no other option if we are using BCLC, childhood B, right? So lenvatinib and all the immunotherapies are, as per guidelines, are ineligible, right? If the patient is in childhood B. So it's only a shared decision making between the patient and the doctor, which is required in the tumor board and outside, right? Is it correct what I've heard?
Yeah, absolutely.
Perfect, perfect. So any difference of opinion, Dr. Ishu, and followed by Dr. Javed Mozammil, in your practice also, what Dr. Vibhor have told correctly, do you agree with that, or you want to add on something from your end?
I think Dr. Vibhor has concised it perfectly. And with B7, sorafenib being the only approved drug, however, the practice does become a little lenient, and we do tend to use more effective available options. Although the chance of toxicity, as Dr. Vibhor mentioned, is higher. But again, because you don't have any other options, sometimes you do tend to use them.
Perfect. Dr. Javed, any inputs from your end, sir?
Yeah, absolutely. We have real-world data of lenvatinib as well, in which B8 patients were also taken, B7 were also taken into consideration. And yes, as my co-panelist said, that the toxicity level will increase once the childbirth score increases. So that is there. But we don't have in hand anything more than that we can offer to them. We have sorafenib, we have lenvatinib. Yes, for A and B, always, once a costlier drug you are giving, you want to see that you are having a perfect soil for that. So once you're crossing that Child-Pugh A, so you tend to be on the defensive side, because patients also will ask you about the survival, toxicity, and all that, and financial toxicity as well. So guidelines, yes, it's child class A for all molecules, and sorafenib for B7 as well. But in real world, we are trying to be lenient. We give it to B7, B8 also.
Perfect. So just this is a very important point which you brought, and which always tickles our mind, that what should we do if the patient is having a BCLC, I mean, the Child-Pugh B is there. So I just want to know that we already know of the Himalaya trial in which the durvalumab single agent also is equivalent to sorafenib, right? So whether you're using durvalumab for those patients who are having a Child-Pugh B7, are we correct in doing that?
Yeah.
Or we are wrong?
Yes, if you can see the from the Himalayan one-to-one what comparison, Durva and the sorafenib being the same thing. So now you have to see the other comorbidity status as well. What patient is having, and you have to select the drugs as per that also. You
So
want to
suppose the
see,
comorbidities are
because
not there, sir. I'm just stating the patient is not having any comorbidities, and the patient is having a Child-Pugh B7, whether you will use durvalumab or not.
still, that again a shared decision between the patient and clinician.
Fair enough.
Yes,
Dr.
we can
Vibhor,
use.
I just want to ask you, as you correctly mentioned, that sorafenib is the only drug as per the guidelines, but we have to take a calculated risk and we have to have a shared decision making. So whether you are using durvalumab single agent in B7?
No.
No. Reason being?
Actually, the reason is that in that particular trial, they have shown the superiority in overall survival is only with D plus T combination, right? D is non-inferior to S. That is what the crux of the matter is. Durvalumab single agent is non-inferior to sorafenib. What they have shown, the superiority in overall survival comes only when you are using a D plus T combination. In that study, they have taken only Child-Pugh A. They have not taken Child-Pugh B in that particular trial. So in a B7, I would not be inclined to use durvalumab as a single agent.
Okay. So I think you're in difference of opinion. Dr. Mohit, you want to add on?
Yeah, sir, I just want to put one point. So in Checkmate 040 trial, the nivolumab was tried in Child-Pugh B. Of course, the data is not great, but that has shown some activity in Child-Pugh B, B7. That's what we are discussing. So that formed some basis of role of immunotherapy in Child-Pugh B7. And as you rightly mentioned that in the Himalaya trial, equivalence non-inferiority was shown in comparison to durvalumab versus sorafenib. But in the safety profile, the durvalumab was better. There are, I think, almost 30% or so grade 3 or more adverse event with the durvalumab versus almost 50% with the sorafenib. So conceptually, if we look at that B7, we can think about using durvalumab, but practically as of now, I am not using.
But point to Dr. Mohit is that reflect trial also is a non-inferior design in which lenvatinib was found non-inferior to sorafenib, but we are not using lenvatinib in B7. We are using only sorafenib, isn't it? But on the top of that, durvalumab we are discussing that can be used instead of.
I think in that trial as well, I think 15-20% patients were childbirth B. That's what I remember in reflect.
Right, that's correct. But reflect trial, there was doubling of median PFS, there was a tripling of objective response rates, and but it was not inferior design. So we cannot demonstrate a superiority in reflect trial, but we are not using lenvatinib for B7 also. We are using only sorafenib, isn't it? As per the guidelines.
Yes,
I'm just conceptually only I'm asking. So what is your thought process whenever you are having a B7 or sometimes B8 also, and whether you are taking a calculated risk or you will tell that the absence of evidence is not the evidence of his absence and then go ahead, right? So what is your take? That is what I want to convey.
No, as of now, I would like to say that we don't have any strong evidence for this.
May I add a point?
Yeah, please go ahead.
I think so that in Himalaya trial also, they have taken only childhood A. Please correct me if I am wrong.
Right. I'll be coming to that, but I just want to discussion upfront only before going to the next slides. But yes, majority of patients were having a childhood A. That's correct. Right. So I just want to know, like, durvalumab immunotherapy is no for childhood B and beyond, or some calculated patients you will take durvalumab or some nivolumab as you correctly mentioned. So that is why the difference of opinion is there. But as per guidelines, we stick categorically for that. So we should not go for immunotherapy in childbirth B, right? Anyway, we'll move on for the discussion. So profile of patient with SCC and experience from a tertiary care cancer center, which was published and for Indian Journal of Gastroenterology. So the childbook ABC, it is 41, 45, and 13. MELD score hovers around 9 to 15, which is 11. And BCLC 0 ABCD, it is 1.7, 10.3, 25. Majority patients are child, ABCLC B and C. D are only 13.6. LB score. Now we have come to LB score. So how often you are using LB score? Any of the panelists can take this. So may I start with Dr. Vibor? What is the meaning of LB score, and are you using it in your practice?
No, honestly, I have not used LB score in my practice so far.
So what is the meaning of that? Like why it is mentioned in the literature? It's not practically applicable, right?
No, I have not used it.
Anybody else have used? Dr. Mohit, Javed, and Dr. Ishu?
Sir,
No,
we
we
have
are all
not been
actually
using it, but I think basically Albay score does say that there are certain fallacies with the child book, that the severity of the symptom, that is probably the sign, probably let's say ascites, or sometimes there could be one albumin might be high, still preserved, but bilirubin is also high. That patients would also be scored into a very similar category, and there they try to define that probably Albay is also a score which could help us differentiate certain patients which are though child pug B, but a good albay probably could help us know that these patients are better. I have not been using it, but this is what I know about it.
Okay. So as you correctly mentioned, there is a limitation to the child book score, right? So the key limitation of child book score is that there is a lack of any parameter pertaining to liver cancer itself, right? So LB
Right.
denotes the liver function measure and it predicts the prognosis of the patient with SCC. It is objective and it is reproducible. It can be grade 1, grade 2, grade 3 LB score, and grade 3 carries a very poor prognosis, and these patients are only for transplantation, right? Although it is very difficult to calculate, there is a log rank, the bilirubin in 2.66. There are some criteria is there by which it is calculated. But this is what we have to know about LB score. On the just to move on, what is the most common etiology of SCC in your practice? May I start with Dr. Mohit? Hepatitis, NASH, ALD, or any other parameter?
In my practice, I commonly see hepatitis. Still, I commonly see hepatitis as the most common etiology for SCC. But of course, nowadays, in the past few years, the incidence of NFLD are increasing. That definitely. Because of course, it is a obesity pandemic. So I think that might be the reason.
Okay. Anything else, Dr. Javed, you can take in your practice?
Yes. It has. I think shifted from last 5 6 years. Earlier, we used to say it is hepatitis B and C. Now it's not that. It's NASH related, followed by hepatitis. Alcoholic liver disease doesn't exist in our cohort of patients. So it is a NASH number one, followed by viral
Perfect.
hepatitis.
I think, Dr. Ishu, are you having the same opinion or are you having a different opinion?
Correct, sir. NASH is the most common cause right now.
NASH is the most common cause right now. So risk factors, as all of us know, that's a viral hepatitis B and C, substance abuse in form of alcohol, tobacco, alpha toxin. The metabolic causes are NASH, obesity, the metabolic syndrome, and over a period of time, there is a chronic inflammation. There is a irreversible damage of the liver architecture and vascular architecture leading to cirrhosis, which, if associated with immunosuppression, leads to SCC over a period of time. The longer a patient lives with cirrhosis, more likely the patient is going to get SCC. And the 5-year cirrhosis, there is a 10% increase in risk of SCC. Remember that. Etiological factors of SCC, with the background of cirrhosis, multi-center study was done, and it was published in 2023. And the most important thing which came out from this study is that the most common etiological SCC was NAFLD, that is non-alcoholic fatty liver disease, followed by hepatitis B and C, and the harmful levels of alcohol, which are the most common causes. And this study is done in India, right? The multi-center study of SCC in the Kerala, the more than 1,200 cases, majority of them, that is 44% of patients were having an NAFLD, 7% of the patient hepatitis B, hepatitis C, on contrary, it's very, very small percentage, and alcohol is 40%, right? So it is NASH-related fatty liver disease followed by alcohol, followed by hepatitis. This came out and it's published in May 2023. So this is what we have to understand. So what scoring system do you consider while treating SCC? I think all of us are using Childhood score. There is no doubt LB score is having its own difficulty in calculation, and that's why Childhood score I think we are all using. So updated BCLC, the staging system which have come in which we know that the only way to cure cancer liver is ablation, liver transplantation, and resection, by which we can increase the lifespan of the patients. So this all of us know this is updated this thing based on the tumor burden, the liver function, and the physical status, and defined by the alpha fetoprotein and the Child-Pugh score, right? So what is the preferred choice of treatment for first-line unresectable SCC in your practice? May I ask Dr. Ishu, what is your practice? All the options are there in first line. Which one you are inclined towards in your practice? Affordability is not an issue.
So, sir, for past few years, with the data of I am Brave being most, it has been some time that the data has been out. We have been using Atezobev as the first line. With this current data of Himalaya, uh, there are patients who are BEV ineligible because of their own proteinurias, hypertensions, and their varices. This could project to be a very potent and a very good choice. That's the durvalumab.
Okay, so if treatment is available, patient is affordable, and AB is already with us. So which one will opt for? The patient is having a mild hypertension. All of us are having mild hypertension, right?
Right.
And
So
we are
I don't think there's any data. It's not there. I know Atezobev versus Durvatrem. Theoretical numbers could be better with Durvatrem, but very difficult choice. I don't think it is data supported. It would probably be just like experience support, more of like I would still go ahead with Atezobev right now, but would like to use Durvatrem also sometime.
Okay, so Dr. Vibhor, your take?
Yeah, so
affordability is not an issue.
Yeah, so Atezobev and Durvatrem both are there in the first line. Also, this Checkmate 9DW of Nivo EP has also shown an excellent overall survival advantage, although that is not yet in the guidelines, but it might shortly also come up into the first line. But one point I would like to point out, as my co-panelist has already said, we have to look at the contraindications of using BEV. That can be one decision-making factor. Second, in the Durva-Trem study, the exclusion criteria was main portal vein invasion. If you look at the Atezobev study, they have included those patients with main portal vein invasion, and they have also included patients with large bulky disease. Third point, the response rates in the Atezobev trial was 36%, and in the Durva-Trem study, it was 20%. So these are the although this is a cross-trial comparison, with all the limitations of cross-trial comparison, I feel we have to keep these factors in mind while choosing our patients for Durva Trem versus this one, atezolizumab Bev. And in future, as we have this Emerald 1 study, as it comes into practice with patients who have been exposed to TACE and durvalumab and bevacizumab in the BCLC-B category. Now, when these patients will ultimately progress and they will get into the unresectable category, that might also have some bearing upon our first line choice of drugs. But as of now, out of these two agents, these two regimes which have been uh, uh, approved, so that is these are the points that I can think of about choosing between these two.
I do agree to each and every sentence which you have told. All of us are aware about the data of atezolizumab. All of us are aware about durvalumab and tremelimumab. We know that the tough to treat population in which the bile duct involvement, major portal vein involvement, and when the liver tumor is occupying more than 50% of the liver, they are all included in atezolizumab trial. And majority of patients were A6, A5. None of the patients were in B, child book B. And only problem is that how to handle those patients who are non-viral and how to handle those patients who are bevacizumab ineligible, right? And Dhruva Trimi answered that question, because of which we are inclined towards that. But having said that, I already mentioned that, and you correctly mentioned that Nivo EP also is now data is there. But how to select? These are the factors which you have to keep in mind. But affordability is not an issue. Patient wants to take the latest drugs. In that case, what you will use, whether you will go for atezolizumab, because Dhruva is having a 3-year survival benefit also published, right? 1 out of 3 patient is crossing 3 years, right? Which is amazing. On the whole, numerically, atezolizumab is having a good overall survival benefit, 19.2 months median, and China cohort have got an overall survival of 24 months. So numerically, atezolizumab is still scoring better as far as median overall survival is concerned, but durability wise, durvalumab is having 1 out of 3 patient crossing 3 years. And there are many more who are going to, this is 50% I'm telling, there are many patients who are going to live beyond 3 years, which is unprecedented. So how will you choose? Because tremelimumab is only 1 dose, first dose in stride regimen. After that, it's durvalumab only, which is continued. Upfront, nearly the cost of first dose will be around 9.55 lakhs. But over a bit of it is single agent durvalumab. So whether you will be inclined towards Durva or Nivo EP, because that all data is there, and Nivo EP is available for more than 5 years now. What is your inclination if affordability is not an issue, is the question. Dr. Vibhor.
So in my practice, I am still, I have never used Durva Trem so far. But yes, in case there's a patient who is ineligible for BEV because of various factors, hypertension, CAD, history of recent history of stroke, proteinuria, any of those factors, then Durva Trem can certainly, I would consider that. And even Nivo EP also, because if you look at the OS, the best OS is there with Nivo EP. It is 23 months.
Absolutely right.
Nothing has crossed that much. But then
Correct.
we don't know the nitty-gritties of the patient population, because in the Nivo EP trial, even in the sorafenib and lenvatinib arm, the median OS was 20 months, which is way beyond what we usually see with the, these TKIs. So like my practice, I am more comfortable with using atezo-bev at this stage, and that's how I would. But in case of bevacizumab ineligibility, I would like to go with the pure IO combination.
Absolutely right. I do agree what you told. But NCCN 2024 guidelines, Neo EP, they have not kept as category 1 recommendation as of now, although that is amazing of Neo EP. Only point is over a period of time, I think in 2025 it will come as category 1 recommendation itself. And even tislelizumab also is category 1 recommendation in first line setting. I don't think we are having access to that. Any light, anybody can throw light on this? Have you gone through the data of this? Dr. Mohit, you can take this. Durvalumab single agent also is category 1.
I think there was a trial of regional number, I forgot. For that is letrozumab. I think that has shown non-inferiority to sorafenib. That's what I remember. So it's non-inferior to sorafenib. It's not superior.
Right, it's not superior. Okay. So category 1, durvalumab also single agent also category 1. Suppose the patient is bevacizumab ineligible, whether you can start durvalumab single agent? you are getting away with Vivaswam anyway, right?
I would love to use durvatremi if the patient is having contraindication for bevacizumab. So I would like to because it's just a single dose, and of course the
Suppose
loss of
patient is not
survival data
affordable
is
for Trimi, durvalumab
if patient is
still
affordable,
affordable.
affordability is not an issue, and there is some contradiction to BEV, then of course I would like to use durva-tremi rather than using single agent durva, because that has shown superiority in comparison to sorafenib, while durvalumab was non-inferior to sorafenib
Have
in
you
the
ever thought
Himalaya
of
trial.
combining durvalumab plus ipilimumab? There was no trial for that, and it was there with us as far as treatment going for more than 5 years now. And tremelimumab just came 2 months back. We are having hands-on experience in melanoma. Durva ipilimumab is a viable option? No, although it's a CTLA-4 inhibitor. Have you ever thought?
Sir,
Yeah, the
very
concept.
frankly, dual IOs is not very, very easy. And we are talking about melanoma's experience where, organ functions are perfectly fine with your liver functions being totally fine. Even there's a good challenge of at least 1 in 5 or maybe more than that, there is dose stoppages, reductions, everything. So I'm not really sure how patients will tolerate a dual IO, one. And two, sir, as when we were choosing, the cause could sometimes help us in future, although I don't have any experience with Durvatrem. But then again, there is data saying that NASH patients would probably respond better with Durvatrem cross trial compared to the other
I do
regimen.
agree
So
what you told, but the point
yeah.
is it's only single dose of Trimi, right?
So we definitely can. The single dose of, yeah, you should. If it is available, if the trial and if the real world experience is also good, maybe it will overtake Atezobev and we might be giving it.
Perfect, perfect. Right. So what is the average oral survival you observe in your patients with advanced SCC with the current standard of care? So may I ask Dr. Vibhor this? Right now we know all these drugs in the first line. What is the oral survival in your practice?
See, by and large, keeping the theoretical aspects apart, in 90% of the patients are still going on the TKIs only, right?
Right.
And with the TKIs, the average survival that I'm seeing in practice is around a year, maybe +3, maybe -3 months. So 9 to 15 months. That is the range. With Atezobev, some patients that have experience with using Atezobev, they are definitely doing better if they are stringently in the Child-Pugh A criteria. If you are using, I remember one patient I had used Atezobev in B7, but I don't think I will like to do that again based on the experience that I had. It does not actually lead to prolongation of any tangible benefit over TKI. That is what my experience is.
Perfect. So
9 to 15 month range.
how many patients you have crossed Atezobev for more than 25 cycles?
More than 25 cycles, none.
None. Dr. Mohit, in your practice, how many maximum number of cycles you have given in Atezobev?
That was not actually my patient, but of course the years crossed 30, 35 or something. A patient is there
Okay.
who strictly fulfilling the criteria of Atazobab. Now more than 3 years it is there, and he's still doing well.
Still on that drug, or you have stopped it because of progression?
So see, after 3 cycle, patient went away, so I
Okay,
couldn't.
fair enough. Dr. Ishu, how many like maximum cycles of Atezobev you have given by now?
Sir, none of my advanced HCCs, frankly, have crossed 2 years.
Okay.
Very frankly, and the maximum number of cycles that I've gone with for Atezobev is probably somewhere around 14 or 15, not more than that.
14 or 15. Fair enough. Dr.
Yes.
Javed, in Srinagar, how many maximum cycles of Atezobev by now you have given? Because the data is there for more than 5 years now.
10 is the maximum
10 is the
for
maximum.
me.
Okay.
Yeah.
So the answer which I got is not more than 25. For only Mohit, one patient is there who have crossed 30, and none of the other panelists have crossed 15, right? So this is what is the actual ground reality, because we are using it right, left, and center for past 5 years. Durvatrimi, I'm very sure that all of us either will not have any experience or will be having 1 or 2 patients because the drug came in just 2 months back, right? Anyway, this is the unmet need, and we have to think of keeping these patients as good as possible for as long as possible. We want to maximize the overall soil benefit, and we want to preserve the quality of life, right? So sorafenib
Yeah,
already.
Dr. Naginder, since we have these two drugs, I am brave and this Himalaya. So besides, they are both for the category one uh, as a recommendation. So based on the, if you see the forest plot, even though they have been recommended for alcoholic liver, this cirrhosis, for hepatitis, viral hepatitis B related or whatever. But if we look at the forest, it has been touched by the previous speaker as well. That if we look at the forest plots also for the Atibev, alcohol, this NASH people did not do well. If you look there, that hazard ratio was almost close to 1. And if you look here now, Himalaya, it's 0.78 for NASH related SCC. So if we have to select by that way as well, so all NASH will, if there are no contraindication to immunotherapy and cost challenges. So I think this is going to pick up this, Himalaya is going to pick up in our practice if there are no cost constraints. Because the NASH related issues, NASH related CLD and NASH related SCC is coming up and viral. And similarly, if you see hepatitis C related here, uh, that is crossing the unity. Hepatitis C related with the Himalaya. So not a good drug. I cannot say that for this C related the SCC, but a very good drug for NASH related SCC.
Absolutely right, sir. You are bang on to the point. So hepatitis C, Himalaya trial was not showing the good survival benefit. It was crossing line of unity. And you correctly mentioned that non-viral SCC patients, atezolizumab also is not a good drug, although it was still on the right side of line of unity. The quantum benefit was limited for a non-viral SCC. And in the front, when I started this presentation, I told that majority of patients, all of us agreed that NASH-related CLD or NASH-related etiological factor is more common for SSC cause. That is why our practice is changing, and we are searching for the best drugs for NASH-related CLD going for SSC, right? So durvalumab is holding ground in reversible eligible NASH-related. Only thing is the hepatitis C, it have not shown benefit as per the trial. Anyway, I will come to this all questions we have discussed in our discussion. So do you think that we need to explore a different pathway uh, other than anti-VEGF to combat SCC? So do you agree? All of us agree, I guess. Dr. Mohit, you can take this.
Yes, sir. There are other pathways as well. I think the study has shown that now it is NTRK, and of course RAT should also be looked. So there is some role of NGS, though we are not using it frequently. But other pathways should also be explored. And of course, in the apart from PD and PD1, there is of course CTLA for that's a TEMI. So that's always already there. We are exploring it.
So is there any role of NGS in HCC? Dr. Vibhor, can I ask this? Because we know that there is a non-invasive diagnostic criteria, that is AASLD, American Association of Study of Liver Diseases, and we are having a EASLD, that is European Association of Study of Liver Diseases. That was a non-invasive diagnostic criteria by which we are diagnosing SCC. So now we are talking about NTRK. How will you find NTRK unless we do a biopsy, isn't it? So for that, already drugs are there which are showing good response, although they are category 2B. So are you up for doing a biopsy in all the patients with SCC, or are we not there yet? Dr. Vibhor?
No, in practice, we are not doing the biopsy in case there is clear radiological evidence of HCC or AFP is high. If all the factors are like falling into place, then as of now, we are not doing a biopsy. If we are, if there's something, some reason to suspect that this might be a mixed cholangio-CA HCC kind of a thing, then yes. Otherwise, I don't think so that we are doing biopsy. I am not doing
Why
it.
I asked this, Dr. Vibhor, suppose in lung cancer, we know that if we are having an EGFR mutation or ALK mutation, we know that immunotherapy is not going to work. Similarly,
Yes.
for SCC, we have picked up that patient is having NTRK or any other mutation. We know that these patients are going to fail atezolizumab or durvalumab just because immunotherapy is not going to work. There are patients in our practice in which atezolizumab we are given for 4 cycles. We did the first response assessment and the patient had progressed. right? So how to find out that who is the ideal patient for SCC, for Edizobab or Durvalumab or Nivo-IP for that matter? Until we do biopsy, we'll never come to know that this patient is going to fail or not, isn't it?
Yeah, that I agree with you that for NTRK mutations and all, we need to do the biopsy and need to check on that. But it is, suppose even if we get a NTRK mutation positive, uh, in the first line, are you going to use the standard approved agents, or are you going to use the NTRK target
That's the whole
therapy?
point. That's
Yeah.
why I raised this point. Are we there yet to do a biopsy upfront? We all know about the non-invasive diagnostic criteria, but are we there yet? Because the science is dynamic, it's changing. We know that we should not do any biopsy. SCC is a cancer which can diagnose without any invasive biopsy. But how to find out those patients who are having a primary resistance to atezolizumab or primary resistance to any other immunotherapy combination drugs? We will never be able to find out a correct biological or biomarker by which we can tell that this patient is going to do well and this patient is not going to do well, just because the molecular testing we have not done upfront, isn't it? So are we there yet or not? This is a question which I want to ask. Dr. Javed, you can throw light upon this in your practice.
Yeah, biopsy actually now, as you have already touched upon the SSLD, biopsy, there are definite criteria for the biopsy. We don't do biopsy in all the patients now. If there are, we have doubt in diagnosis and the images
No,
are not
that we all
characteristic.
agreed. That we all. This is what the school of thought is. This is what we are trained in the medical college, that we should not
Yeah,
diagnose with biopsy. I'm not debating that. I'm debating whether we should do biopsy now onwards, because there is so much explosion of literature is there as far as the molecular information of SCC is concerned, right?
yeah. You are talking about the NGS also. You are talking about how should we do NGS, but there are also liquid biopsies. We don't have data for that also, but liquid biopsy is coming up. We can pick up the NTRK in liquid biopsy as well. And basically, in SCC, we don't have that much time. Most of our patients, they come so early. So that's why we have not explored more and more molecules. I don't know how these dual immunotherapies will go. They have crossed the 3 years also. 1 in 4, 1 in 5, they are surviving. So these are the patients who once they progress, those are those patients that 1 out of 5 who may live for 5 years, 6 years, 7 years. There we require those molecules. So definitely, maybe in future we are going to get something on that.
I buy your point. The point is, in our practice, we have seen that first response assessment only the patient have failed. We promise that if we start Durva Trimi, 1 out of 3 patients will cross 3 years, but they have not crossed 3 months also. The disease have progressed. So how to find out those patients who are going to get a primary resistance to the standard drug? This is a question which is pending solved, right? And we have to address that in next couple of years. Otherwise, we will lose those set of patients, because if they have progressed on Durvatrimi, we are stuck. We don't know what should be done, right? We have to give
Yes,
them
yes,
just TKIs for whatever benefit which we cannot promise, because Durvatrimi have not worked. What will work, we don't know, isn't it? So this
yes,
is a question which
yes,
is always there on the table. Anyway, so Himalaya evaluates the durvalumab with or without tremelimumab versus sorafenib in first line unresectable SCC. And there is a tried regimen. We all know that there is a single dose of tremelimumab 300 milligrams single dose along with durvalumab 1500 mg IVQ4 weekly. It was arm A. It was 1:1:1:1 randomization. Arm B was durvalumab single agent. Arm C was sorafenib, and arm D was prematurely closed. Right. So it was stratified based on the major vascular involvement, with the etiology of liver factor, whether it's a HBV, HCG, or performance status. The primary endpoint of this trial was overall survival, although the key secondary endpoints are highlighted here. So this drug, only one dose of tremelimumab is there, and then only single agent development is there.
Dr. Nagendra, sorry to
I'm just
interrupt.
coming. I'm
Can
coming.
you? Yeah.
Within less than 5 minutes, I will
Okay,
close
sure.
this. These are the baseline characteristics. I think all of us know about this. STRIDE regimen demonstrated statistically significant improvement in the median overall survival versus sorafenib. At 36 months, 30% of the patients were alive as compared to 20% in the competitor arm. So there was 22% lesser risk of death as compared to those patients who are on sorafenib, right? So we know that 1 out of 3 patients are alive with STRIDE regimen. This is practice changing, and this was never heard of in advanced SCC.
Sir,
Yeah.
can I make a small interruption here?
Yeah, please.
In the same chart, when I went through this, there was a question since beginning. We see here that 20% of the patients on sorafenib are also alive at 36 months. Well, I don't know if there is that experience with anybody else. that patients on first line sorafenib advanced HCC have made it to 3 years of survival. I'm not really sure if anybody has, and if you know, maybe.
It's not the majority of patients who have
Yeah,
3 years. 1 out of 5, like 5 patients you started sorafenib, only one was able to cross 3 years, which can happen, right? The
correct.
overall survival of SHARP trial, which was published, was 10.7 months, vis-a-vis
Hmm.
7.9 months, which was just placebo, right?
No,
Based on
that's what 1 in
data.
5 also is probably a way too high number in real world is the question that I have.
Absolutely right. This is a good point.
Yeah.
But the
Yeah.
point is, this was the highly selected population, and only hepatitis C virus have not done well. This is what came out from this trial. This spike is
Correct, sir.
really valid,
Correct.
but number was very, very minimal. Anyway, durvalumab single agent has shown a non-inferiority in overall survival improvement as compared to sorafenib, as you can see clearly. And your thoughts on durvalumab monotherapy? Have anybody of you have used durvalumab monotherapy? Just quick yes and no. Dr. Vibor, have you used durvalumab monotherapy in your practice as of now?
No.
No. Dr. Ishu?
Nope.
No. Dr.
No.
Javed?
No, from no,
No.
no, no.
And Dr. Mohit, you can also comment?
No.
No. Okay, fair enough. Any specific population which you will prefer durvalumab or combination? I think already you have mentioned, so there's no point in discussing that. Duration response was 22 months as compared to 16 months with single agent durvalumab, and sorafenib is even lesser. Majority of the side effects are manageable. We all know about how to manage autoimmune side effects which can happen because of Duro and ipilimumab. And safety profile, I think we are not having any hands-on experience of now, but on the whole, it's a safer drug because only one dose of ipilimumab is there. So to conclude, SCC is one of the topmost common cancer affecting Indians. There's a shift from the viral to non-viral etiology, which have happened in last couple of years, which we have witnessed. NAFLD is responsible for more SCC cases in the current era. Atezolizumab plus bevacizumab has been the new standard of care in advanced SCC. The STRIDE regimen, that is single agent tremelimumab at the dose of 300 mg, along with durvalumab, improved the overall survival versus sorafenib and demonstrated an unprecedented 3-year overall survival rate. 1 out of 3 patients as per data was crossing 3 years. STRIDE seems to be benefit across all subgroups, including the non-viral etiology patient, excepting bar SCV, which Dr. Zaved Muzammil correctly mentioned. STRIDE was well tolerated with low rates of discontinuation and gastrointestinal hemorrhage. Durvalumab monotherapy is non-inferior to sorafenib for oral survival with the improved safety profile. STRIDE and durvalumab monotherapy represents a potential new treatment options for patients with unresectable advanced NCC. So ultimately, in advanced NCC, the dictum when we cannot cure. So the dictum is cure sometimes, treat often, and comfort always. This is what we should be opting for, and we should make sure that our patient live longer and live better. And that can happen once we discuss this patient in multidisciplinary tumor board, not only upfront when the disease outsmarts the treatment. And I think this is a golden era of advanced disease management. Over to organizers, please. Thank you. Thank you very much, all the panelists and audience. Over to you.
Thank you very much, Dr. Nagendra.
Thank you.
Thank you. Thank you, sir.
Thank you so much, Nagen sir, for discussing the management of SCCs and how we are going to be discussing things in the near future with so many insightful discussions. I think the discussion between the etiology of shifting from viral to metabolic causes and what's the difference in the treatment and survivals. And the second very important fact, which always comes to my mind also about what you talk about the NGS. So I think that is something which is required in liver as well. And although that conventional teaching of not doing a biopsy hinders us from making this SCC treatment, how we are treating other cancers. So the basic biology and the drivers, what are there, needs to be discussed, and NGS is the only way. One other thought which comes to my mind that if we try to do or if we try to avoid the biopsy, can liquid biopsy substitute in SCC? That is also one area which needs to be thought of. So with that, I think and I need to thank all the panelists for actively discussing about the first line management of SCCs. And thank you, everyone. Thank you, Horizon, for organizing this event.
Okay, thank you so much, Dr. Ankit and Nagendra sir and all the panelists to join the session. And thank you to all of them for thank you for participating day 1 and day 2. And thank you, Yashika, to support me. And thanks, tech support. Thanks, good night, sir.
Thank you. Good night, everyone.
Good night, sir. So tech support, can you close the meeting? Tech support.